Discussion. We'll start again. Hello and welcome to Hernia Patient Support Group and to our live chat discussion where we talk to our expert surgeons about all things hernia. So I am Jackie and I'm one of the group admins, and I'm delighted to be joined tonight by Mr. Neil Smart, who is a consultant colorectal surgeon from Devon and is here today to talk to us about parastomal hernias. So welcome, Neil, and thank you very much for joining us tonight.
Thank you for having me.
So I think before we start our discussion, as I understand it, there's three types of ostomies. You've got an ileostomy, which is a stoma created from a small bowel. A colostomy is stoma created from a large bowel. And the urostomy is a stoma created from the bladder to drain urine. Is that correct?
Broadly, I mean, there are subtleties as well. So you can have things like jejunostomies as well, which is the more proximal part of small bowel. And you can also have other things like gastrostomies and esophagostomies, but they're really niche, fine print things that you don't really need to worry about in the context of what we're going to be talking about this evening.
Can any of these ostomies develop parastomal hernia?
The ones that you've mentioned, the three main ones, are the ones that cause the problems. The others are small print.
Okay.
Very rare.
Depending on the literature, what you read, the estimates of anybody with a stoma getting a parastomal hernia is between 50 and 70%. Why are the rates so high?
Well, there are some people, like the great John Gallagher, who is a famous colorectal surgeon in Leeds, back in the 60s and 70s, used to opine that a parastomal hernia was an inevitability if the patient lived long enough. So those rates might be low. The problem is the concept of parastomal hernia is actually a tautology, because a stoma is, by definition, a hernia. You've created a hole in the abdominal wall, and one of the intra-abdominal organs herniates out through it. We've deliberately done that. We've made it that way. And what we're asking is that that hole remains the perfect size in perpetuity. And that's against the laws of nature and against the laws of physics. That's just not going to happen. So if you live long enough, you'll get one eventually.
Okay. So what actually is the parastomal hernia?
That's a brilliant question. And I don't think there's actually a universally accepted definition. Some societies, like the European Hernia Society, have tried to come up with a definition. But the problem with them is they're very, I would describe them as surgeon-centric. And they tend to talk about anatomic details that are visible on a CT scan. And that's not really orientated to what's important to patients. And there are patient-orientated definitions which have been used by some researchers, such as colleagues from Denmark, for example, which are much more attuned with what patients experience. So that's things like saying parastomal bulge. So any sort of bulge that occurs near a stoma. And whether that is what some surgeons or anatomists might describe as a true hernia, or whether it is siphon loop, which is where you get a subdermal prolapse, doesn't really matter, because it's what's important to the patient that matters. And some of the other things, well, they're really splitting hairs. I think the best way of looking at it is like the Danes suggest. If you've got a bulge near your stoma, that's good enough for me.
Yeah. So when we talk to patients about hernias, we often say that watchful waiting is a valid treatment option. Is this also the case for a parastomal hernia?
Oh, that's a great question. So I think what we can say is that out of all the management options that exist for parastomal hernia, watchful waiting is by far and away the commonest thing that happens. And that's because most patients with a parastomal hernia get managed by an expert stoma care nurse. And they are brilliant. And most of them have got fantastic tips and tricks up their sleeve for helping with managing the problems that arise because of hernia, and whether that is things like using support garments to help provide a bit of extra support to help take away pain and discomfort, whether it's additional tips and tricks about how to get the appliance to stick onto the abdominal wall skin over that slight bulge, with extension strips, or whether it's a stoma belt, whatever it may be, they're the most common management things that occur. And for many patients, that's all that's required. But we know that in the long term, about a third of patients do end up needing some sort of surgical intervention. And of those, for about 7 or 8 years, about a third of them end up having a recurrent intervention of surgery of some description or another. So surgery still has a place. Watchful waiting definitely has a place.
So we know that hernia is more than a physical condition, and it affects every aspect of a patient's life. You and I, we've had several conversations, haven't we, about the theory of Marmot and the patient deciding on the two most important factors about their lives, which they would change. So we encourage our patients, our members, to question themselves about their hernia and how it affects their lives, not just physically, but psychologically and sexually and socially and financially, because hernia impacts on every part of our lives. And I think it's when we understand how it affects us, if then the patient can decide if surgery is the right option for them. Would you agree with that?
Oh, very much so. I think that MIMOP concept is really important about understanding what matters to you. And the thing is, those three things that you highlighted right at the beginning of our chat this evening are really important, because patients with different stomas will have different things that impact them, particularly when they get a hernia. And we know that the index surgery that led to the stoma and what the condition was that led to it will have an impact on how the parastomal hernia affects the patient. So, for example, we know that patients who get parastomal hernias for stomas that were created for benign disease tend to have a worse impact on their quality of life. And we know that patients who have hernias around an ileostomy tend to have worse impact on their quality of life than patients who have a paracolostomy or a paraurostomy hernia, for example. So there's some important nuances that really do matter and can be unique to each individual patient.
Okay. So if the parastomal hernia rate is so high, the recurrence rate is so high, why should patients consider surgery?
So I think surgery has something to offer if patients have got certain particular problems. And I come back to using an analogy of other things that are not permanent but can help improve quality of life for a period of time. For example, if you've got arthritis of the hip, you might choose to have a total hip replacement. But that total hip replacement does not last forever. They are finite, they are limited, they last for about 20 years. But you're not going to turn down benefit for 20 years because it's not going to work forever. And it's the same for surgery. So if I said, well, look, we could make things better for you for a period of time, and during that time, you could work, you could earn a wage, you could come off benefits, you could live your life, you could play with your grandkids, whatever it may be, then that's worth having. And I would argue that recurrence rates are not the right measure of success, because I would argue that recurrence rates are 100% if you live long enough, because that hole will get bigger over time and it will come back. What matters is how your quality of life is impacted. That is everything.
Yeah. So at the moment, you're currently involved in a study, aren't you? The PROFA study. Do you want to tell us what this is actually looking at with the parastomal hernia?
So I think it's fair to say that as a community of surgeons, there are many of us who are involved in looking after patients with parastomal hernias who really don't know what the best way to manage patients is. What symptom burden justifies operating? What would be the degree of problems that patients experience that make the risks of surgery worth taking? And if we're going to operate, well, what operation? How should we do it? What type of mesh should we use? Where should we place it? And much of this came about because we had a patient who was really proactive come to a number of us and said, well, look, I've had 6 parastomal hernia repairs. None of them have worked particularly well, and I've had lots of complications from them. And I think we need to think about this better. And Sue Blackwell, who many people in the community may well know, has helped design and set up and get the funding for this study, working with the team at the University of Birmingham, led by Tom Pinkney. I think it's the first time that I can think of in the field of hernia surgery that the study has been led by a patient, really designed by them, and that's been first. And I think it's really exciting for us as surgeons to start thinking about conducting studies that ask questions that are much more pertinent to patients. So it's about, how has your hernia been managed? Has it worked for you, whether it be surgery or non-operatively? And are you happy with the decision that you made, or do you have regret? Because there are times when we might fix a hernia, we might have no recurrence, and there might be no recurrence detected clinically or on a scan, and the surgeon may think, oh, aren't we wonderful because we've cured them of this problem. If the patient's got complications that adversely impact their quality of life, we have not done them a favour. And this study will capture that data in a way in which none others have done in the past. I think that's really exciting.
So is this study just a UK-based study, or is it a global study?
So at the moment, it's only open in the United Kingdom, but we have got plans to open it in North America as well. We've got partners there. And there is going to be some translation into European languages. So we're hoping to launch it in non-English speaking countries too. So we've got plans to translate into a number of European languages, both North and Southern European languages. That work is ongoing at the moment. But at the moment, just the UK for now, but it is going broader soon, hopefully. So anticipating North America by the middle of this year, hopefully at the latest.
And can patients actually request to be a part of this study? Can they say to the surgeons, well, I've heard about this study on a Facebook support group. I want to be a part of it. Can we do this?
Yeah, so a lot of the sign up and getting the consent is done through an app that patients sign up to themselves. And what we try and encourage is patients asking, are you part of this study? If not, why not? And I think that patient power is really important. And the idea has been that we've tried to put the research into the hands of everyone in the multidisciplinary team, not just surgeons, which is the traditional way that research has been run. We've tried to empower stoma care nurses in particular to be the people who are trying to encourage recruitment. So particularly to capture those patients who are managed non-operatively. I have to say, increasingly, as we see more and more sites sign up, if you're a site who's not engaged in that research study, I think perhaps as a patient, I would be wanting to know, why aren't you? Are you not interested in this condition that I've got?
Fair comment is that, really, isn't it? Because, parastomal hernias, not everybody's going to do massive quantity of them. And you want to know that the surgeon is invested in what's right for the patient and the patient outcome. So that's a fair comment.
I think so.
Yeah. Okay. So patients actually decided that they're going to go ahead with the surgery. Who are the best surgeons to do this? Is it going to be a colorectal surgeon or a hernia expert?
That's a really tough question. Different healthcare services around the world have differently organized healthcare systems. The one thing I would say is that perhaps the title of the person doesn't so much matter. What matters is that they've got the appropriate knowledge and skills. So what does that involve? Well, I think the one thing we can say is that you get good at what you do lots of. So if this is something that you do once a year, you're never really going to get good at it. Whereas if it's something that you spend all your time doing and you're passionate about, you're much more likely to get better results. In some healthcare systems, the people who will tackle this are called hernia surgeons. And if they get great results, that's fantastic. In some services, it will be colorectal surgeons who have to deal with it because they create the problem, so they have to fix them. And that's often the way in the NHS, in the healthcare system in the UK in which I work. There can be advantages where you have synergies, where you have colorectal surgeons, but who do a lot of hernia work because they will have a deeper understanding of the underlying intestinal disease that led to this stoma being created in the first instance. So particularly as we see increasing complexity, particularly of things like inflammatory bowel disease management, that's going to become more and more important. So who's the right person? Well, you'll know them when you see them. And if you know what questions to ask, you'll be able to tease it apart. But it's quite hard to get the level of insight, I think, to get those questions out and scratch the surface.
Yeah. You see, we always recommend to our members that they do question the surgeons about their experience. And I think any surgeon should be happy for a patient to ask that, because at the end of the day, it's our bodies that we are trusting you with. And we need to know that you are the right person for the job, basically. So do you have any suggestions about questions what patients should ask?
So I think the questions that I would ask a surgeon if I was going to see them about something, it's the standard thing that we ask is, what is it in your training that makes you the right person for this job? So if someone turns around and says to you, well, I did a dedicated fellowship in abdominal wall surgery, that's usually a good starting point. And if someone has said as well, I've got a particular interest in parastomal hernias and I do large volumes of these, that's also a good sign. Now, some healthcare systems have taken things a step further and they've actually organized their healthcare services such that such cases are corralled into specific hospitals and specific surgeons. And Denmark's a really good example of that, where for their 5.5, 6 million population, they've limited the elective repair and indeed the emergency repair now of parastomal hernias to just 5 centres. And they published their data about what that did for their health service a couple of years ago in the British Journal of Surgery. Actually, it wasn't the elective repairs where they made a big difference, but for emergency patients, they had dramatic positive benefit in terms of reducing the rates of deaths, reducing the rates of reoperation, emergency readmissions. So it pays dividends. So it's that same thing that we see time and time again, where high volume surgeons get good outcomes. So asking, do you do this lots? Or am I just your one patient a year where you dabble? That's fair.
It is fair. It is fair comment. So is there anywhere where patients can find out this data?
Sadly, I don't think there is. I wish there were. I very much think that there should be. And I think there are examples of surgeons putting data into the public domain, and they've done it for things like lots of cancer surgery, done it particularly in the United Kingdom where it's in the public domain. They've put it online for cardiothoracic surgery. And we know that when surgeons do this, they do not game the system. It does not deter people from taking on high risk cases. That has been proved. Most surgeons are okay with their data being transparent. As far as I'm concerned, I'm a public employee. I work in a public healthcare system. Not just my data, it's your data too as a taxpayer. Absolutely, you should have my performance data in the public domain. I have nothing to hide. And I
No.
would quite happily have it on there for hernia too. But at the moment, the NHS doesn't mandate that. It only does it for cancer and vascular surgery and heart disease at the moment. So, but it probably should do more and more.
I think so. I mean, we've had patients who said to us that they don't feel that they can ask these questions from the surgeon, and if they do, then the surgeon will discharge them and tell them to go. Well, that's not the right surgeon for you then.
Indeed, the one problem we have in the United Kingdom is that, unfortunately, in the way in which the NHS collects data, there is no code specific to parastomal hernia. Trust me, I've been looking for years and asked for it for many, many years, but we don't have it. It's hard to get that data out at the moment.
Okay, so A patient has found a surgeon that they trust and they've decided that they're going to go ahead with surgery. What are the surgical options?
I mean, surgical options are legion, and it all depends upon what type of stoma they have, what type of hernia they have, how the index operation was done, whether it was keyhole surgery, robotic, open surgery, and I suppose the type of symptoms that the patient has and that what bothers them most. So, as a general principle, things I want to know as a surgeon is the patient fit for an operation? What was the intestinal disease that caused the stoma to happen in the first instance, or urological disease, as it may be, if they've got a urostomy? And is that still an active problem, or could it be an active problem, or could I make it worse by doing something with the um, operation I'm about to do? So, for example, if a patient has an ileostomy, the things that are going through my mind for patients who've got ileostomies because they've had Crohn's disease are completely different than when I think about patients who've got ileostomies that they've had made for cancer. And the surgical options are worlds apart. So it really is that level of nuance. And I don't think you can sit there and say there's a one size fits all approach for hernias around this type of stoma of this size or that size. I don't think it works that way. It's much more nuanced. That's why you need someone with appropriate expertise.
Yeah. We heard recently about some surgeons, they'll rejoin the bowel, won't they? And create a new joint and then move the stoma to somewhere else. I've heard that's been done before. But is rejoining the bowel the answer?
So there are some patients for whom restoration of gastrointestinal continuity is the answer to their problem. That's fair. But it isn't the answer for everyone. And just because you can doesn't mean you should. And I think you've got to be really searching in your questions about whether or not to do that. Because if you give someone a terrible quality of life downstream but cure their hernia, have you really made them better because they've now got fecal incontinence? Not certain. As for moving stomas, controversial, I think is the best way to describe it. I don't think there's an answer which involves always or never. But what we do know from the data that we have from multiple countries, whether it's Korea, but more recently the United States, with great data that's come from the Michigan group, is that patients who have stomas moved tend to do badly because they end up with a new parastomal hernia at the new stoma site. They end up with an incisional hernia at the old stoma site, and usually an incisional hernia at the laparotomy that was made to facilitate moving from A to B. Making multiple holes in people's abdominal walls is really, really a good solution to a difficult problem. I'm not saying I've never done it. It's just that it's often not the best way forward.
So recently we've seen a few members who've seen surgeons and they've offered to repair a parastomal hernia without mesh. Now, to my mind, you're increasing the risk of a recurrence there, aren't you, with any incisional hernia, because you've already had the if it's a recurrence, you've already had the original hernia there. What would you say about the use of mesh? I mean, we tell patients with mesh about mesh to question the surgeons as to what they're using and why. Is that a fair comment for parastomal hernia?
So I would say this, there are times when repairing parastomal hernias without mesh is a reasonable thing to do. And that is usually when the patient is in extremis. They've often got a strangulated parastomal hernia and they are at risk of dying. And in those circumstances, particularly if, excuse me, the bowel is perforated, there's infection or contamination around, you don't want to put mesh. In those circumstances, your mission is to save life, get the patient out of the operating theatre, and if you can, get them out of hospital alive. And we should not underestimate how risky emergency parastomal hernia surgery is. It's got a very high mortality rate. If you're in an elective situation, repairing parastomal hernias without the use of mesh I think is not recommended by the guidelines from the European Hernia Society or from the Association of Coloproctology of Great Britain and Ireland. And that's because the recurrence rates are unacceptably high and they occur quickly. And I think if surgeons are doing that, you've got to ask very good questions about what is it they are hoping to achieve and how does that align with the patient prioritization. That should happen through things like MIMOP. In terms of the mesh that are being used, I think it's absolutely fair to ask questions about what mesh, where are you placing it, and how. And I think so long as the surgeon can give you a very good justification about what their technique is and that they know their data, and they can tell you that there is a low complication rate and that there is a good outcome for the patient as measured by the things that we've already discussed, then that is fair. There are many surgeons who will say in their hands that they get excellent results with technique A, but a surgeon might elsewhere might not be able to replicate that. That is surgery. That's what happens. And I don't think there's a panacea. I don't think there's a one size fits all.
No, no, I agree with that. So we talk a lot about the benefits of prehab and how prehabilitation will give patients the very best chance of a successful outcome. And I guess with parastomal hernias, this is actually very, very important, isn't it?
Possibly even more so. I mean, there are certainly some circumstances where I think it takes on an even greater magnitude than perhaps just simple incisional hernia or even sort of the colorectal surgery to give the patient the index stoma. So, for example, smoking cessation, I think, takes on a particularly important aspect because of rates of wound infection, failure to heal, recurrence of the hernia, but also because of the disease that underlies it. So, for example, if patients have Crohn's disease, smoking makes that a lot worse. And well, the chronic cough that comes with it means that the hernia repairs for any parastomal hernia will fail much more quickly if the patient's still smoking. So prehab becomes really important, I think.
Yeah. So are there any specific nutritional advice you can give to a patient preparing for surgery with a parastomal hernia?
That can be difficult because often if you're trying to do weight loss, some of the weight loss diets can conflict with some of the stoma specific diets, particularly if the patient's getting some degree of obstructive symptoms. So often people will talk about a healthy diet, being plenty of fresh fruit and vegetables, for example. That can be very hard if you've got an ileostomy and you've got a degree of incomplete small bowel obstruction because it's stuck within the hernia sac. Because those bits of advice don't work for you. And it can also be difficult when you say, well, let's look at ileostomy diet sheets where you're avoiding a lot of that stuff. And if the patient has, for example, poorly controlled diabetes, so having lots of things like, white bread and some of the calorie dense foods that we often advocate to patients in those circumstances don't necessarily work well if they're trying to control the diabetes, it can be really hard. And sometimes you need expert advice from a dietitian.
Yeah. What about exercise? Because I know it's hard to exercise with a hernia anyway, but I'm sure if you've got a hernia and a stoma, throw that into the mix, it could be even harder, even more difficult to exercise to lose weight.
So I tend to chant a mantra to my patients, and I tell them all that weight is lost in the kitchen, fitness is gained in the gym. So most of weight loss, about 90% of it happens with what you eat, both quantity and quality, and exercise has a relatively minimal role in it. But exercise is super important for your cardiorespiratory fitness. And I think in terms of surgery, it's the cardiorespiratory fitness that I'm really after. Not so much interested in the abdominal wall musculature.
No.
So I don't mind whether people do things like core four exercises or any of that stuff. It doesn't bother me. What I'm interested is people getting the heart and lungs working. And a lot of patients say, well, I find it difficult because I've got this football-sized bulge around my stoma. I have difficulty getting the bags to fit. I don't want to go swimming because everyone's looking at me. I can't go outside and run because of the weight. So doing those aerobic things are difficult. So I say in these circumstances, the best thing to do an exercise bike. You can buy them really, really cheaply online now, and you can even get them secondhand for 20, £30. That's what, about 30, €35. You don't need to spend a lot of money. I'm not asking you to win the Tour de France. You just need to be on them. And because it's indoors, you can do it in any weather. What you really need to be doing is exercising enough to make you short of breath, so you cannot talk in a full sentence. That's the level.
Yeah, I must admit, during COVID, I got myself an exercise bike and I did the YouTube videos on the bike. So that's a thing. And there are also the NHS seated exercises, aren't there, that you can get online?
Yeah, and if you can't do the sit on an exercise bike, particularly say patients who've got paracolostomy hernias because they've had an abdominal perineal excision for rectal cancer, and they find an exercise bike too difficult to sit on, then you can get the pedal exercises that you just sit on the floor and you can sit on your sofa and do it. They're just as good. So whatever works for you.
Whatever works for you is right. So what if at the other end of the scale, the patient's decided then that surgery isn't the right option for them? How can we support them as they live with the hernia?
That really comes down to having expert stoma care nursing and making sure that all of the accoutrements that they need, whether it be additional stoma supplies, that they've got access to them, support belts, and if they want the support garments, making sure that they find support garments that work for them. There are loads of things on the market, and there's an absolute plethora of different manufacturers, different designs, whether it be support knickers, whether it be support vests, whether it be belts, or whether it's more medical looking corsetry. There are lots of different options. I think the stoma care nurses are absolutely vital for helping the patients navigate the way through that complex choice of finding what's right for them. Because there's nothing worse than having, the garments that you get on prescription, for example, in the UK, and then they're never worn because they sit in the back of the underwear drawer because the patient doesn't like them because they're
Yeah.
too itchy, too scratchy, the weather's not right, and they sweat too much. It's of no use if you don't wear it. So,
No,
but if you've got
I've got one like that. It's in the back. It's just like, it went straight back in the box, right at the back of the cupboard, and it's never been used.
and it's so if you're not wearing them and not using them, then they won't work. But if you get them and you get the right one for you and it gives you the confidence to do what you want to do, fantastic. That's the most
Absolutely.
important thing.
Yeah, I think with the garments, you're wearing them for such a long time. It is so important that they are comfortable, really
Yeah,
comfortable.
absolutely. And sometimes patients may have to say, well, it can be choosing when to wear them. So you don't have to wear them necessarily in bed at night, but it's about choosing them at the right time, for example, about, if you're going to go and do certain activities, that's when you wear them.
Yeah.
Whatever works for you. Again,
Okay, so it is worth mentioning maybe that in England, patients are entitled to these on prescription. I'm not sure Wales and Scotland are different. They've got different healthcare systems, but definitely in the UK, in England, they are entitled to these up to 3 per year. And companies like Vanilla Blush, they can sort it all out for you and help you sort that out if you're not going through your stoma nurse. So they can be quite expensive, so to get them on prescription is quite a help, really, sometimes.
it is. And what I would say, though, is that for some of the ones which are perhaps not quite stoma specific, this is where I'm probably incriminating myself about revealing I know far more about ladies' underwear than perhaps I should. But so things like Spanx, some patients swear by them and say it's great and it works for them, and that's fine. They're very expensive, but you can buy non-branded variants off the high street for a fraction of the price, and they are just as good. And if they work for you, probably much better that you're paying £5 to £10 a euro rather than the 60 or 70 that you're paying for the big
That's
name
fine.
brands,
Yes.
and you don't have to spend a lot of money. You
No.
really don't.
No. So, if how can patients prevent a parastomal hernia from occurring? Can we do that? Is that something that can be done? Can we prolong it at all?
I think again that's controversial. So can things be done by the surgeon at the time that the stoma is formed? to prevent a parastomal hernia, while there is some evidence that for patients getting an end colostomy for cancer, that using mesh prophylactically in the abdominal wall helps. And again, the European Hernia Society and the ACP-GBI guidelines would advocate that. Can the patients do anything themselves? Well, I think that's very difficult because, as we discussed before, a stoma is a hernia by definition. And if you want that hole to stay at the same size in perpetuity, is there anything that you can do to keep it that way? Well, not being overweight will probably help, so keeping your weight down. Not smoking, because that impairs wound healing. And it also avoids you getting a chronic cough. But otherwise, I think many of the factors are outside of a patient's control. For example, one of the most important factors that predicts development of an incisional hernia of any type on an abdominal wall after rectal cancer surgery is the use of neoadjuvant radiotherapy. That's radiotherapy you give before the surgery. That increases your risk of developing a hernia significantly. The patients have no control over that. Other things like avoiding heavy lifting. Does it make a difference? Well, thing is, the force that you put through the abdominal wall when you cough or you sneeze is 5 to 10 times higher than the force that you put through from heavy lifting. So avoiding heavy lifting isn't going to help you because I can't stop you coughing, I can't stop you sneezing. The doing exercises or wearing support garments help. The evidence is slim to non-existent, and I can't see any high quality evidence to say that it makes that much of a difference. Support garments may make you feel more confident. Are they going to stop you getting a hernia? Can't see how they're going to alter the biology of the disease, I'm afraid.
Comment. Okay, so we talk about patients having the stoma because they've got cancer or something like that. So if a patient's got a low life expectancy because of the cancer, would you, and they develop a parastomal hernia, would you repair it? Where would we go with that?
So the issue with a lot of cancer patients is often many of them are more elderly. So patients who get their stomas because of cancer tend to be older on average than patients for perhaps who've got stomas because of inflammatory bowel disease, for example. But sometimes patients can and do live a long time with a stoma after cancer surgery, so it can still be worth doing. And there are certain circumstances when fixing hernias around a stoma can be useful or indeed important. And there are occasions when we've had patients who've had parastomal hernias, but who've had obstructive symptoms who needed something doing, even though they had metastatic disease. And if they had metastatic disease, but they needed palliative chemotherapy, they can't get the chemotherapy if they're having episodes of obstruction. Sometimes you do hernia repairs as a palliative procedure to facilitate other treatment that patient need. It really is all about that multidisciplinary team discussion, engaging all the members of the team who are looking after the patient, oncologist, anaesthetist, the patient themselves, and presenting the options to them.
Okay, so there's been a lot of talk recently. I mean, we were on the meeting the other day, and we were talking about patients with quality of life. And I think for English people, we're very much taboo. We don't talk about sex and things like that. It's a bit of a stiff upper lip and it's swept under the carpet. And it's something that patients find difficult to talk about, but it's important to patients. And I think for patients, for parastomal hernia patients, it must be hard for them because I mean, it's hard enough when you've got a belly full of scars and lumps and bumps in places that you shouldn't have. But add that with a stoma, you've got a bag. How can we help patients to see the body more positive?
I think there are a number of things to tease apart here, and I think in the past we've been, and certainly the government have used this language too. I think we've been unfair and almost pejorative about using things like or terms like it's just cosmetic, and that's really unhelpful. because cosmesis and body image is actually fundamentally important.
Yes,
And
it
I
is.
do think that there are times when, particularly for patients, I mean, if you've got patients with very large parastomal hernias, when they are at an age when they may be very young, body conscious, and they are not yet having had all of their family, when there's things about sexual identity are really important, that those things actually do matter and are good indications for surgery in their own right. I don't think you have to have severe pain. I don't think you have to have multiple episodes of obstruction from the hernia in order to get your operation. I think having a grossly distorted body image and unable to have intimate relations, which is a normal activity, can be justifiable because some of the patients have real difficulty with, for example, if their hernia causes their appliance not to fit properly and they leak lots, their partner won't sleep in the same bed as them because of the nighttime leakages. The partners put off them, they lose sexual interest and desire, and it can be devastating for relationships. So I think we do have to recognize that the indications for intervention, whether that be non-operative or operative, need to be much broader. And I think we need to be much more holistic in our assessment of patients. And that's why I think that MyMOP concept really comes to the fore.
Yeah, I agree with that because it is taking the life as a whole, isn't it? And it's the little parts of life that make the bigger picture, and we have to look at those smaller parts. So another question we've had is, what are the warning signs to watch out for with a parastomal hernia?
So I think if they enlarge rapidly, that's the time when you think maybe we ought to consider seeing a surgeon. And the reason I say that is because they do get larger over time. Both the aperture in the abdominal wall gets larger, and the sac, which contains the contents that have come out, gets larger. And there is a balance to be struck between watchful waiting and operative intervention, because what we don't know is as hernias get bigger, are they more difficult to fix? Does the risk go up? Does the rate of recurrence after you fixed it increase, and do they come back sooner? Are there more complications from the operation to fix it? So are you better off fixing things when they are at an earlier stage? It's a simpler operation, it's easier to do, return to work might be quicker, all those kind of things. And it's about having that conversation and just exploring your options. It commits you to nothing going on a fact-finding mission. The other thing that I think is a useful thing to think of as a warning sign is when you get episodes of obstruction. And it's worthwhile asking the question of why. Because when an obstruction happens, sometimes the hernia becomes more noticeable. And the question is that cause or is it effect? Because there could be other things going on that are causing the blockage, adhesions, recurrence of the underlying disease process that led to the stoma. So things like Crohn's strictures or cancer recurrence or whatever. But that's when it's worth getting checked out. And that might mean scans, imaging, so you can assess what's going on. And again, it's about exploring what's happening, commits you to nothing, but it puts you in a position of getting all the information that you as a patient need to make the decisions that are right for you. And if your answer is at the end of it, thank you, but no thanks, I don't want an operation, that's fine. But I think it's perfectly reasonable to ask.
Okay. So what is the recovery process for a parastomal hernia repair? What sort of support and care will patients need after surgery? Because for any hernia repair, it's not an easy recovery sometimes.
No, and I think the most important person before the operation is probably the stoma care nurse. And the most important person after the operation is most likely the stoma care nurse. And I don't say that glibly, but there are significant changes often in stomas after they've had parastomal hernia repair. So the aperture's changed and the relationship of the aperture size for the actual stoma compared to the size of the flange on the appliance can alter. So you're going to have new templates. You're going to have all of your prescriptions redone. And that's a big deal. And all of a sudden, you're going to go from having a large bulge to having flat stomach, and there can be issues relating to where the stoma sits, into wounds that may exist on your tummy wall. So all of that's important. In addition, I think a good relationship with a physiotherapist is important too, because often we've ended up doing things to the muscles of the abdominal wall. And if we've fiddled about with them, or even if we've cut some of them in order to close the hernias that exist, you can then end up in a very difficult situation with having to learn how to move again. So, for example, some twisting motions can be very difficult. And the classic one is getting in and out of a car. I mean, we're all aware nowadays that the car parking spaces seem to be getting ever narrower, and you have to be a contortionist when you get in and out of your car. But that twisting motion that people like me take for granted every day, for patients who've had a recent abdominal wall hernia repair, that's a very different undertaking. Or just learning how you get out of bed and how you have to use your arms to help you sit up and roll out, those types of things. That's where physiotherapists come into their own. And thinking about perhaps some of the core exercises that you can do when your surgeon and physiotherapist are happy to help build up your core strength again can be really important.
So what follow-up care do patients with parastomal hernia have? Because I know with normal hernia, there isn't always follow-up, is there? So do you as surgeons
Be very
monitor?
limited, because particularly in some healthcare systems, you're not reimbursed for doing repeated follow-ups. So, for example, you might have an early follow-up to make sure that the wounds are okay and that there's no sign of wound infection or breakdown. But thereafter, you're not going to follow patients up in perpetuity as a surgeon. But usually there's an ongoing relationship with the stoma care nurse, and they will probably be the first people to notice whether there are issues related to the bulge coming back. So if that's the case, that's the route back into then a surgeon for further reassessment.
Okay, magic. So what about the carers? Is there any support for carers of people with parastomal hernia? Or is that something that they have to look to the local council and local charities for?
So many of the stoma care nurses will do joint training and teaching sessions with the carer. So particularly if a patient needs input into having stoma bag changes because they're not fully independent for whatever reason, whether it can be dexterity due to arthritis or whether it's to do with neurological dysfunction so that the hands don't work properly. We often find that stoma care nurses are great at doing training with the carers too, but they could need a significant amount of support after hernia repairs. And so, for example, often what we find are patients who are things like obligate wheelchair users, or if they've got neurological diseases like MS, who need parastomal hernia repairs. There's a lot of input that has to happen with the carer and upskilling the carers and about how the change in abdominal contour impacts the patient and how it alters how you might change the stoma appliance afterwards. So a lot to do. And sometimes you might have to have medication that alters the consistency of the fecal material that comes out to keep it slightly on the softer side or looser side so it goes into the bag. You don't want it too hard and pushing the appliance off, and issues with relating to pancaking. So there can be important roles for the stoma care nurse and education for the carers too.
Another question's come in. Is being underweight as dangerous as being overweight?
Depends why you're underweight. And the answer to that is it can be. And in particular circumstances, particularly our patients with Crohn's disease, they can have a lot of issues with malnutrition. And there are occasions when, in order to get the hernia repair facilitated, they may need a period in hospital to have their nutrition optimized. So there can be some challenges, yes.
Okay. And I think we've asked the other one, haven't we, about specific nutritional advice. Is there, I mean, when I had my colorectal surgeon, I was on an enhanced recovery program. Do they do that for parastomal hernias? Is that recommended?
So there's no data specific to parastomal hernia that I'm aware of. There are some generic enhanced recovery programs that people have talked about with regard to abdominal wall surgery. Most enhanced recovery programs really focus on minimization of things like starving people for prolonged periods of time and stopping them from mobilizing. And that's largely gone from the culture nowadays of surgery. But I think the days of us being able to do things like robotic surgery for really complex hernias as a day case are probably still limited in Europe. Some of it is happening in North America, but it's not quite there yet. Give it another 10 years, and when I think some of the minimally invasive techniques have hit prime time a bit more, I think we'll see even more.
Okay. So another question's come in. We know that every surgery has got a risk.
Yep.
What are the specific risks with parastomal hernia, and how can we reduce those risks?
So the first risk, obviously, is the risk of recurrence. And as we've already described, I don't think it's a particularly good or useful metric. But the other risks that come with parastomal hernia repair are essentially the complications that one gets with any major abdominal surgery. And there are those that are things like wound infections and the usual bundles that people use to try and reduce wound infection. There's risks that are generic to having major surgery, DVTs, PEs, those types of things where, early mobilization, use of compression stockings, low molecular heparin, all that type of stuff. The same as the index surgery that led to the stoma. For parastomal hernia specifically, I think the challenge is that when you take a hole in someone's abdominal wall, which is that big, and you want to make it that big, the question is, have you got it just right? Because it's the Goldilocks principle, isn't it? You want it not too big, not too small. You want it just right. And I have to say, it's hard, but there are occasions when it might make it a little bit too snug. That's hard to get right. That's where you need experience. And particularly if you start using bits of mesh and make it too tight, there are theoretical risks about the mesh complications that can occur with erosion and fistulation. Thankfully, they're all very uncommon, but they do occur. Is there anything you can do to mitigate against it? Having a high volume surgeon and someone with lots of experience.
Yes, I think that's really one of the main take-home messages from tonight, isn't it? If you have a parastomal hernia, we need a surgeon with high volume experience of treating patients with parastomal hernias. It's not just a case of sending back to the original colorectal surgeon if they don't necessarily repair parastomal hernias.
Absolutely.
I think I've learned actually quite a lot tonight about parastomal hernias, because it was one thing that I've never really understood much, but I have actually learned a lot from you, Neil. So that's really great. Thank you. But taking my take-home message from this is that it's not something that you should necessarily rush into surgery. We have to stop and think, and maybe surgery isn't always the right answer, as it isn't with every surgery, every hernia. We don't always need to have an operation to repair it. Sometimes we're okay to live with the hernia.
I think that's fair. And I think I cannot emphasize enough going on a fact finding mission to know what all your options are does not commit you to any particular course of action.
Yeah.
Being fully informed and knowing what's open to you is the first step in the process. You're not duty bound to go further if you don't want to, if it's not the right thing for you.
No, I think that's the one thing what we have to get through to patients, isn't it? That they have got the power and they've got the ability to say no. If you're not comfortable and you're not happy with any part of your treatment, you are allowed to say no. It's your body.
Absolutely. And the patient has to be the one comfortable with it because they live with the consequences.
Absolutely.
It's not the surgeon.
Yeah. So one last question that I had from Mark, and that was, what was the best donut filling?
Raspberry jam. Definitely raspberry jam.
We shall make that known. Okay, so thank you, Neil, for joining us tonight. It's been lovely to speak to you. I'm
Thank
sure
you for
we'll
having
speak
me.
again very soon. And
Thank you
thank
very
you,
much.
everybody, for joining us tonight. Take care.
Thank you, everyone. Take care. Bye
Bye.
bye.